Thank you for joining today's webinar on PDPM, CMS Potential Audit Areas. My name is Christina Brenderman. I'm the Director of Denials and Appeals with TMC. I've worked in TMC's Denial Prevention and Management Department for 3 years, and I have been a speech-language pathologist for 12 years. Medicare Part A audit changes. We know that when PDPM is implemented on October 1st, the Medicare Part A audits will be changing. This is expected as currently many of the Medicare Part A audits pertain to verifying RUG levels that are being billed. Since RUGs will no longer be in existence, the nature of these audits will have to change. During this webinar, I will be outlining the areas that CMS is expected to audit under PDPM. The first area is changes in payment that occur from a result of skilled nursing facility coding compared to actual changes in the case mix. Accurate coding in the MDS is going to be critical across the board. ICD-10 diagnoses are going to impact all 5 of the case mix suggested payment categories, and that includes physical therapy, occupational therapy, speech-language pathology, non-therapy ancillary, and nursing. ICD-10 codes will capture the primary reason for the skilled nursing facility care in MDS item I-20B, and I-8000 will include additional active diagnoses to classify the residents for the PT, OT, and SLP PDPM payment components, as well as for the non-therapy ancillary. For section I-8000, there are 10 spaces for non-therapy ancillaries and SLP comorbidities. If the codes used are not active or are not supported by documentation, that could result in a denial if it is audited. Facilities will only be able to use codes that aren't listed as return to provider on the MDS for section I-20B. It is also important to point out that facilities are going to be audited on the ICD-10 codes. If a reviewer audits the documentation, they should be able to come up with the same principal diagnosis and additional diagnoses as the facility did. If the auditor does not, then a denial would likely occur. The nursing component is going to be important for PDPM as well. It is based on the RUG for non-rehab RUGs to classify residents based on the use of extensive services and the presence of specific clinical conditions such as, is the patient comatose, do they have pneumonia, do they have sepsis, etc. They all require an active diagnosis within the 7-day look-back period. Section GG is going to be important in PDPM as well. Documentation must be present to back up each GG score, and for that, auditors will look at both the therapy documentation as well as nursing documentation to see if what is entered on the final GG report on the MDS matches. The second area that we expect to be audited, and we think this is going to be a really big one, is changes in the amount of therapy services that are provided to residents under PDPM compared to RUGs 4. CMS has mentioned that the care is not expected to drastically change. Reimbursement is going to now be driven by the characteristics of each patient rather than the amount of rehabilitation minutes that are provided, but the amount of therapy should not change if therapy has been historically provided based on what the patient needs. CMS has discussed that they think PDM will create fraud reduction because they currently feel like the care is being provided based on financial gain rather than patient need. CMS has stated we do plan on monitoring that and seeing how much of a change occurs along with changes in the patient population. So if care does suddenly drop on October 1st, that could indicate that the care that was being provided prior to then wasn't based on the patient need. Our understanding is that CMS is going to take a wait-and-see approach, and that wait-and-see approach might wait for 6 to 12 months so that they can monitor the trends. And then if the care does significantly change, audits would likely occur where they look at both the care that occurred during RUG 4 prior to PDPM and then the care that occurs once PDPM starts. Documentation is hugely important now with RUG 4, and it's going to continue to be important under PDPM. The therapy and the nursing documentation will need to clearly support the patient's reason for why they need care. And a big thing with this is if auditors look and they see that a patient prior to October 1st needed 720 minutes, and then afterwards the patient needed much less, there's going to need to be documentation that really supports that. And if that documentation isn't there, then it's going to look like the drop just occurred because rugs were no longer in play. CMS has indicated that if they see a decline in minutes occur consistently, that decline could be used as a way to justify reducing payments in the future. The third area is skilled nursing facility compliance with the group and concurrent therapy limit. The group limit and concurrent limit is a per discipline combined limit. So what that means is that each therapy discipline, physical therapy, occupational therapy, and speech language pathology, will have their own 25% cap for group and concurrent therapy, and that is over the course of that resident's stay. So to track this, CMS has created a new item on the discharge assessment to calculate the compliance with each therapy's 25% cap. Non-compliant providers will receive a non-fatal warning message on their validation report. CMS has stated, we will be watching to see how often that warning pops up. If we see that warning popping up a lot, that is going to trigger something. We know from experience when they say it's going to trigger something, they would be doing audits on those claims. It's important to note that the definitions of group therapy and concurrent therapy are changing under the final rule. Group therapy is now defined as 2 to 6 patients doing the same or similar activities, and concurrent therapy is defined as treatment of 2 residents at the same time when residents are not performing the same or similar activities. Despite CMS's policy change on group, CMS does discuss in the final rule that individual therapy is still considered the primary mode of therapy and standard of care and therapy services. If facilities are not using group and concurrent therapy prior to PDPM and begin using it afterwards, that could become a target for audit. The big thing is CMS has warned about remembering to consider the individual needs of each patient. They stated, we do not believe it would be appropriate to automatically provide the maximum amount of group and concurrent therapy permitted under the percent cap set by Medicare without considering the individual clinical needs of each patient. What that means to me is that they're going to just be looking to see, is every patient exceeding the group limit, or is every patient even meeting that group limit? They really want to see that not every patient is at the same level of group, and not every patient is appropriate for group. So the documentation will need to support why each patient needs group, and group can be very beneficial, but they want to see that it is individual and that it varies from one patient to the next. And according to CMS, over the past decade, they really haven't seen group and concurrent therapy a lot, but I do believe that they are expecting to see it increase some, and that's why they're saying it wouldn't be appropriate to automatically give that max amount to every patient. It's important for us to remember that the therapy provided should be tailored to fit each resident's specific needs. Concurrent and group therapy modes should not be provided unless the resident will benefit from it in some manner. If CMS sees a large increase in group, they might do audits and then look at, are the functional outcomes for those patients improving, or are they decreasing or not improving? And does that correlate to the amount of group that they're receiving? So not every patient is appropriate for group, but group can be extremely beneficial for some residents. CMS has stated that its preferred method of delivery is individual, as we've discussed, but CMS has included these other modes of therapy, such as group and concurrent, to allow clinicians the option to provide the alternate modes if it's determined that that's in the best interest of the resident. The fourth area of audit is an increase in the amount of mechanically altered diets will be monitored. As you know, mechanically altered diets is something that can increase the daily rate for the SLP case mix of PDPM, and that's because mechanically altered diets and swallowing problems are used to calculate the daily rate for ST. So if there's a large increase in the amount of altered diets, that could indicate that those diet changes are for financial gain rather than patient need. If there is an increase of patients that have mechanically altered diets, but there's not good speech therapy or nursing documentation to support it, that could result in a denial. We suspect that if there's an increase in MDSs that are marking mechanically altered diets, that those claims might be looked at, and if they're looked at, an auditor is likely going to want to see, is the patient receiving speech therapy services to address the swallowing deficit? If we've triggered on the MDS that there is a swallowing deficit and they've got this altered diet, but speech isn't involved in any way, that will need to be explained why, and they're going to be really wondering why speech therapy wasn't involved. But if speech is involved and they're looking at that documentation, they're going to want to see more than just this patient is on swallowing therapy in order to decrease their risk of aspiration. They want to see the real detail of what led to the diet change. So prior to this patient being hospitalized, they were on a regular diet and thin liquids. While at the hospital, they had a decline in swallowing, and they're now on puree and honey thick liquids. So you've shown what they were before, shown what they are now, and then to really document what you're doing to improve their ability so that they don't have to remain on that altered diet. And then the next thing that we think auditors will look at is the altered diet because of a true swallowing deficit? So this sounds funny, but there's patients who are consuming diets like a puree diet because their dentures cause them pain when they wear them. So they don't have a true swallowing deficit, but they prefer to eat puree because it hurts them to wear their dentures, and they're safest eating puree and they get the best nutrition, but they don't have a true swallowing deficit. The fifth area is overutilization of cognitive impairment as a payment classifier in the SLP case mix. Cognitive impairment is another area that increases the daily rate for the SLP case mix with PDPM. If cognitive impairment is indicated on the MDS, but it's not supported in therapy or nursing documentation, a denial would occur. We feel like if there's an increase in the number of cognitive impairments marked on the MDS, that's going to increase audits just like we think it will with an increase in mechanically altered diets. So the documentation must be in place where these impairments are supported on both nursing and the therapy side. The reason that CMS is putting an emphasis on residents that do have cognitive impairment require typically more resources, and so that impacts the daily rate. 10 of the 12 SLP-related comorbidities that also can affect the SLP component are Section I items that require an active diagnosis either in a checkbox or as a comorbidity that is listed on Section I-8000. I mention that because if we've marked in a checkbox or we list a diagnosis in Section I-8000, but that claim is audited and the diagnoses used aren't active, that will result in a denial. The sixth area is an increase in early discharge or less services being provided could trigger as the facility attempting to avoid the variable per diem adjustment. As you know, the PT and OT portion of the daily per diem rate decreases by 2% every 7 days after day 20. Providers are going to want to be careful that they're monitoring there's not a trend of early discharges from PT and OT just because that rate is dropping. CMS has shown that PT and OT patient care does decrease over time, but the documentation will need to support that if there's a drop in treatment or the patient is discharged from those therapies, that it was truly necessary in time for that, not that the patient was discharged or their amount of therapy was dropped because the rate is decreasing. So that's something that just the documentation will have to clearly support, either continuing services at the level they are or support that it was appropriate to go ahead and slow down or to discharge. The seventh area is patients with chronic conditions will likely be audited to identify trends related to the variable per diem adjustment. This one is big because it will be important for the non-therapy ancillaries that get triggered by comorbidities listed on Section I of the MDS. Non-therapy ancillary costs include things for medications, laboratory services, respiratory therapy, and medical supplies. The comorbidities that are listed in Section I-8000 assign points to the codes used as a way of predicting the cost when caring for patients that have these diagnoses. CMS has proposed using these comorbidities to help facilities because of the increased medication costs and increased services that patients with these comorbidities need. You can only add the diagnosis if it's active and it cannot be resolved. So if the codes used are not active and they're not supported by documentation from the physician and in the chart itself, then that could result in a denial. The eighth area is the use of the interrupted stay policy. This is a new rule under PDPM that if a patient discharges to the hospital and then they return to the same facility by midnight of day 3, it is not considered a new admission, but rather a continuation of care by using the interrupted stay policy. CMS has done this as their way of trying to reduce facilities from discharging patients that have a high drug cost and trying to readmit them to obtain the first 3 days of front-loaded payment again. Frequent readmissions are something that will be scrutinized by CMS, especially if they fall just outside of that 3-day window. And if they do, chances are they would look at the documentation from their stay prior to being discharged to the hospital, look at the documentation from when they were discharged at the hospital, and then look at their readmit stay to see what has changed with the patient and what is happening with the documentation. Okay, so I've talked a lot about areas that are going to be audited with PDPM, but it is expected that CMS will continue to audit many areas that they already do. So, for instance, medical necessity and if services are reasonable and necessary, those appeals are not going to go away. We feel like they will continue to look at these areas because what makes services medically necessary and reasonable and necessary aren't changing under PDPM. So it could be even that if a reviewer audits a claim just to strictly validate are the ICD-10 codes used present in the chart and is there documentation to support them, but that doesn't stop them from reviewing the documentation to see, is it medically necessary? And they may look at that and say, you know what, we don't think nursing and or therapy were necessary in this case, and then they'll go ahead and deny it. So we just wanted to point that out, that those types of denials likely aren't going to go away. Thank you for your time. I hope everyone has a great day and weekend.